Good morning. This is Babak Larian, and this is Dr. Babak Azizadeh. We're here to do a Facebook live session on facial nerve and parotid issues.
Thanks for tuning in to us today. So today we wanted to, I think Dr. Larian and I have been collaborating and working together for over 20 years. We did our residency training. After I finished my fellowship, I came back to Los Angeles, and we've been collaborating, operating together, picking each other's brains, and really doing a lot of advances in slightly different arenas. But today, the one thing we have in common is the facial nerve, which we've been fortunate enough to interact with one another, also do a lot of surgeries together that are complementary and synergistic, especially with parotid area. Dr. Larian, for my viewers, if you don't know Dr. Larian is a head and neck surgeon. He is a specialist in parotid surgery, and the facial nerve, as many of you guys know, travels through the parotid gland before it comes out and goes into the various muscles of facial expression. And as a result, when you're doing a parotid surgery, you need to really understand the nerve anatomy. You need to know when this nerve needs to be preserved, when it can't be preserved, especially if you're dealing with a cancer of that area. So we work together in making sure that the decision making is fantastic. Dr. Larian is an amazing surgeon that knows how to access this gland through little teeny incisions and preserving the facial nerve, and then together we work together in reconstructing the area, making sure there's a cosmetic enhancement, as well as preservation and reconstruction of the facial nerve if necessary. So it's been an amazing process, and from 22 years ago till today, there's been a ginormous transformation in how we manage these issues. So today we wanted to do a joint Facebook. We're on both of our Facebook pages, both Facial Paralysis Institute and the Parotid Center. So,
Yes.
all right.
So this has been a fabulous adventure. Both of us had career paths that we thought at first would be divergent, but actually the fact that they were separate and distinct and allow for us to get a better understanding of the parotid and facial nerve from a different angle. I was approaching it from the angle of tumors and removing the parotid gland, and Babak was approaching it from the angle of finding the facial nerve, protecting the facial nerve, or reconstructing for the facial nerve. And so that kind of merged together, and the two expertise really just matched up perfectly. It couldn't have worked out better, in the sense that we now have an expertise for this particular area in both the gland and its function, as well as the nerve and its function. And so when we bring it together, you have the two worlds kind of meeting and maximizing our patients' outcome, which has been fantastic. And it also allowed us to evolve, right? Because we are in the operating room talking to each other, discussing it, thinking of better ways of doing the procedure and helping the person. And it's just always better when you have two brains collaborating on a patient's case and giving you the best results possible.
And that's really key. I think one of the things that, surgery is like the Philharmonic, right? You have a symphony, you have 20 different instruments, and all of those need to be like really coordinated perfectly to get, that's the difference between the New York Philharmonic, London Philharmonic, and some of the other ones that aren't as good. And that's what kind of Dr. Larian and I and our team of anesthesiologists, nurses, technicians, fellows bring to this operation. It's a very complicated surgery because, a lot of times we're dealing with benign tumors that need to be removed, but the potential for, deformity, both whether it's the facial nerve or the area after the tumor is removed or the incision visibility, is very, very high. And so together it's really interesting. I know what he's thinking, he knows what I'm thinking, and in the surgery we have, it's just beautiful. So we really have not only taken advantage of our minds kind of thinking about things, but our really bodies and hands and kind of what we do in the operating room. So it's really, really amazing. And there are, other surgeries that are not parotid related that, I asked Dr. Larian to come and assist me with, because I know the outcome will be better because he will help with various aspects of the surgery that I know he'll know a little bit more and approach it differently, and vice versa. So it's been a really collaborative, amazing experience. And for this, especially for parotid tumors and parotid region, it's been just a wonderful convergence, as Dr. Larian said. So should we start?
Yeah.
All right. Okay. So the first question is the use of a nerve monitor during parotidectomy essential? So I'll let you kind of answer that.
We when we were trained, they were using it on every case, and so we got accustomed to it. And then after my training was over, I was doing medical mission work in Central America, and sometimes these technologies were not available. So I had to do the surgery without the technology. So I had a direct comparison of when using it and when not using it. And that comparison is valuable because I learned even more so when and how I can depend on the nerve monitoring device. So I do use it on every case in the US. I think it's essential for me because as you get close to the smaller branches of the nerves that may not be quite so visible, the nerve monitoring device does give you a warning. And that may be a subtle change and a subtle difference between a surgeon that's using it and not using it. But when you maximize the power of the nerves to the muscles of your face, you can give the maximal smile power and symmetry. And so that's really absolutely vitally important to the person, because when in the long term you're looking at their smile 5 years down the line, 10 years down the line, and the symmetry is still there and even, as opposed to having just a little bit of a difference in that smile, that is actually a very important difference. And those symmetries are meaningful in a way that the person can express themselves. So I really feel that it is essential in what we do.
And one of the things that, so kind of stepping back a little bit, the way that the facial nerve, actually the anatomy of the facial nerve, it's very, very complicated, and it's very different than almost all the other nerves we have in our body, because basically the facial nerve is involved in all our expressions, facial expressions. So we have multiple muscles that help us raise our eyebrow, close our eyes, smile, frown, grimace, pucker. So it's a complicated network of muscles. The nerve transmits basically the signal from the brain. The brain generates the signal of movement, and the majority of it is spontaneous. We're not really thinking about it. It's just happening. And that signal gets transmitted through the facial nerve. And if you think about the facial nerve as a wiring system, right? It first starts out, all the wires are together, and they travel behind the ear, and right below, almost where you could see your earlobe attached to your skin, deep in that area, it leaves the bone and comes out into your parotid gland. And the parotid gland is sitting right in front of your ear to the corner of your jawline. And right there, almost immediately, it divides into two, then divides into 4, 8, 16, 32, and it starts dividing, and these wires start separating and going into the various muscles. And not that each nerve goes to one muscle. Each nerve may go into multiple muscles, and each muscle may have multiple nerves going into it. So it's a big network of wiring that's going in there. So as we go out into this area, as the nerve has now divided into 4, 8, 16, these little branches are where the key function comes along. For instance, for lowering your lower lip, smiling, and so forth. And the nerve monitor, not that it's perfect, and in fact, I would say that if you rely just on the nerve monitor, you're going to get a lot of facial nerve injuries.
Yes.
You have to know the anatomy, and that's why it's critical for the surgeons that perform this operation. They need to do this surgery over and over and over and over and over again, because every patient is different.
Yeah.
in their anatomy, in the way that the nerve is moving, and knowing when to identify and where to identify. It's a very, very intricate operation, and that's why someone like Dr. Larian has so much knowledge, does this every week over and over and over again, and the results are really directly related to your surgeon, his or her experience and expertise, the anatomy, the tumor, the type of tumor, if it's a cancer or non-cancerous, we'll get to that in a little bit. But these are the factors. The facial nerve monitor is very, very important, but these other factors are far more important in your understanding. I would still take someone like Dr. Larian without a facial nerve monitor any day over a surgeon that doesn't have a lot of experience and has all the bells and whistles of facial nerve monitor.
I absolutely agree. I mean, it's not a replacement for experience and meticulousness and attentiveness during your surgery. It's just another tool to help you in the process. And you have to use it just as a tool, not as something you depend on 100%, because it's a machine. It has its own particular idiosyncrasies and failures, and you can't 100% depend on it, but use it as an assistive device to give you the opportunity to have the best outcome possible.
Fantastic. All right, so the next question is, how are tumors of the facial nerve or parotid gland different from Bell's palsy? This is an amazing question, and probably the most critical question of today, because we know all of you who have tuned in to this Facebook Live probably will know more about facial nerve, Bell's palsy, parotid gland tumors than even most internists in the country by the time we're done with this. So you guys need to be advocates, and you need to be, you need to, if you're online, especially with social media, if you see something or hear something from somebody who's reaching out for help, you need to direct them in the right direction. And this is a very critical question, because historically and still today, if you go and see any doctor and your face is paralyzed, the first thing, the knee-jerk reaction is, oh, you have Bell's palsy. Bell's palsy does not equate to facial paralysis in everybody. Bell's palsy is only one type of facial paralysis or facial nerve disorder. And we only call a facial paralysis Bell's palsy if every other cause of facial paralysis has been ruled out. So, I'm going to give you a scenario. An individual walks in or wakes up in the morning and their face is paralyzed. They go in and go to the emergency room. The emergency room doctor performs a neurologic examination, a physical examination of their parotid, of the inside of their ear, do a full examination, and they find no tumors, no growths.
No infection.
No infection. That patient is put on steroids because that's the treatment of someone when we assume they have Bell's palsy, because we have yet not found anything. And over the ensuing month or 2 or 3, the nerve and the muscles start coming back, laugh lines start developing. This person is assumed to have had Bell's palsy, which we then have now found out that it's related to a virus that inflames the nerve right behind, not out here, but you remember we talked about how the nerve leaves the brain and travels through the bone behind the ear in that area. Another scenario could be the following. Someone over a period of weeks or months gradually starts losing their facial nerve function. They start getting weakness. At first, the laugh line starts going, but they're smiling still. Then their eye closure is not as good. They start having this individual most likely does not have Bell's palsy. This individual has some other cause because it was very gradual and it did not happen right away. And so the emergency room doctor can't just put this person on steroids and say come back in 3 months. This person needs to have a full evaluation, MRI, CAT scans, imaging, etc. by a facial nerve expert. So these are two scenarios that are very, very different. And the second scenario, which is one of someone who developed a Bell's palsy or facial paralysis gradually, does not truly have Bell's palsy. So they need to be evaluated. Also, if someone has been given a diagnosis of Bell's palsy and within 3 months they have not gotten any return of function, no laugh line, no movement, that person most likely does not have Bell's palsy and has something else. So that person needs to get the imaging, MRI, CAT scan, be evaluated by a facial nerve expert. So these are the two scenarios that are or three scenarios almost, that are very, very important in determining what is facial paralysis of something that's worrisome, like a tumor, cancer, some other factor, and Bell's palsy, which is a viral-induced facial paralysis.
So Bell's palsy can be a very dangerous diagnosis because it is commonly understood that most facial paralyses are caused by Bell's palsy, but in fact, there is a lot that is not. It's caused by tumors and cancers and infections, in fact. And if everybody's categorized as having Bell's palsy, the doctors will miss a lot of patients who have other causes. So Bell's palsy is a very dangerous diagnosis in my mind, unless everything else has been proven not to be the case, or the timeline and the history is exactly that of Bell's palsy, just like Babak was explaining. So the history of the patient is very important, how the facial paralysis develops, and what kind of a workup that person has had, what kind of experience does the doctor have with seeing patients who've had this, and the long-term consequences of this. So Bell's palsy is common, but it also is only one of the possible reasons for facial paralysis, and an investigation as to other causes is very, very vital for the health of the patient. You know, it's really important. So, you know, and you know, one of the questions is, well, how do you differentiate it? Of course, the timeline, just like what I was describing the two cases, the way that the paralysis comes on is meaningful. You know, a gradual paralysis over several months is not Bell's palsy. And the reason for that is that the facial nerve travels through a bony canal, a long bony canal, to get to the bottom of the ear and come out. And when there's a virus infection of the nerve swells up, and because the canal is bony, it's confined, it strangulates itself. So the paralysis is pretty quick. It comes on quickly. It doesn't take 3 months. You won't have a virus infection for 3 months for it to slowly happen. And so again, the timeline is very important. And when in doubt, you can do MRIs and scans and thoroughly examine the area to make sure there's no mass tumor or infection here, inside the skull, or in the brain to account for it, okay? But let's move on to the next question. Why does benign parotid tumors cause facial paralysis? Very good question. Generally, the benign tumors either have to be so humongous that they're really stretching the nerve, or number two, if they're right at that bony canal, if they're growing at the bony canal and a portion of it, if this is the canal, if a portion of the tumor grows into it, it's going to push on the nerve because there's only so much space in that canal. So if it's pushing on the nerve there, it can compress it and cause it to not function. And then very rarely what you can have is a tumor that may be cystic, meaning has fluid-filled areas, and if that tumor bleeds and all of a sudden that area stretches, right, because there's blood growing into it, it can really stretch a nerve quickly and cause that particular nerve to not function properly. Those are the three scenarios that we have seen in our experience where a benign tumor can cause the nerve to not function properly.
But I would say 99% of the time, if someone has a parotid tumor and they have facial nerve weakness, it's because that tumor is cancerous.
Absolutely.
And it's not benign. So that is a very, 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 significant signal that we have to assume that this parotid growth is cancerous and prepare for the surgery to, and this is what's really, really important, and I think that some of the differentiating factor of how you approach patients is if someone presents with a growth and facial paralysis, you have to prepare to that nerve is involved with the cancer. That nerve may need to be completely reconstructed at the time of the parotidectomy or the removal of the parotid, and that all of that we try to do at the same time, prepare, because if that nerve is involved, we have to make sure that the cancer has not spread along the nerve, both back into the brain as well as out here, and do a immediate reconstruction. And the best outcomes for anyone who has a facial paralysis that's immediately or caused by a parotid cancer is immediate reconstruction of that nerve. And that's what we try to prepare for going into surgery, so that we give the opportunity for the best outcome. Why is this the best? Because your most natural, best outcome is when your brain is delivering the signal to your own facial nerve or a reconstructed facial nerve that's transmitting the signal to your own facial muscles. So if we can reestablish that transmission, the wiring system, we give you the best opportunity of having a spontaneous, natural smile. Now, if the facial muscles are involved with cancer, or if your cancer or facial paralysis has been a long duration, more than 2 years, we don't have the same opportunities. Not that we don't have great options, but we don't have the same opportunities. So we have to use other reconstructive methods, and we also prepare for those at the same time, so that we can take care of not only the cancer, but the reconstruction, so that you can have a great quality of life or an improved quality of life. So this is one of the key things that, I think you have to prepare before you go into surgery. And your surgeons need to be coordinated, understand it both from a reconstructive as well as a cancer, knowing how much of the nerve to take, how much of the tumor to take, what to preserve. We try to preserve as many facial nerve branches as we can. So that, I think, is a very, very important question.
And really the collaboration between us during these surgeries, for these patients who present with paralysis of a branch or two of the facial nerve, is really vital, because we may not be able to determine if that tumor is cancerous or not prior to surgery. The tumor may be in an area that's not easily accessible, or the tumor may be so small that it's not really visible. But we see the paralysis. We know that it's coming from a tumorous process causing it, because we've looked at other issues and excluded them. In any case, so sometimes we have to make decisions about what's best for the patient during the surgery. But in order to do that, we need to have a partnership with the patient, because we need to talk to them in advance, let them know what the possibilities are, so that they are prepared, and they tell us what they're willing to do and what they're comfortable with doing. This is us just doing the most we can to help the patient for what the path they choose in life, right? And that's really important. We are here to help the patients, facilitate what outcome they have, and give them the best possible outcome based on what they want. So the partnership is important between us and our patients.
And sometimes it's benign tumors, or sometimes it's a tumor that we don't know if it's benign or cancerous, and the facial nerve is intact. But when we go into the operating room, biopsies reveal that it may be cancer.
Yeah.
So at that time, we have to make a decision of what to do with the facial nerve, what to do with the lymph nodes in the neck. These are all decision-making aspects that we need to speak in advance with our patients so that they're aware of it, as well as needing to make the correct or the best possible intraoperative decision to give the best possible outcome. And at the end of the day, really, there are three key components. One is, if you have a parotid tumor, want that tumor removed, we want you to be cured or treated for that process. That's number one. Number two is, we want to preserve or create the best possible facial function, facial nerve function, as we possibly can. And the third thing is, we want you to not have a facial deformity where, some people who've had parotidectomies, come in with a golf-sized hole in their jawline, and they're embarrassed to go out. So we want to prevent all of that at the time of the surgery. So we do reconstruction using your own muscles, your own tissues to get your face to be, whether it's a cancer or a non-cancer, to look the best. And sometimes we have to get tissues from other parts of the bodies to reconstruct the area if needed, if it's a more severe issue. So those are kind of the things that we want, because at the end of the day, those are the, your longevity and quality of life are really, really important. All right. This question is actually an interesting question. Can you reverse facial nerve palsy due to parotid abscess?
Yes. So a parotid abscess is an infection in the parotid gland that has caused the central portion of the tissue to die and just fill in with pus, right? So it's essentially a pus bucket. And the facial nerve paralysis that most often happens in this scenario isn't that the facial nerve is eaten by the infection or cut or severed, but rather because there's so much inflammation around the nerve can't function properly. And so yes, it is a reversible process because the nerve is intact, it's not cut by the infection. And so once you correct the infection, and oftentimes what you have to do is either put a needle into the abscess and draw that fluid, the pus, out of the center core of it, or actually open up the parotid gland, open up the area of pus, and open it up so it can drain out and not collect inside. And once the infection resolved, the nerve usually, most of the time, recovers.
Yeah, so this is actually, if you think about it, it's analogous to when someone has Bell's palsy, because Bell's palsy is inflammation, and an abscess or any sort of process can cause inflammation. But a parotid abscess typically is causing the inflammation more out here where the nerves have started dividing, whereas Bell's palsy is where the nerve is all together. So sometimes with a parotid abscess, you get partial paralysis, you don't get full paralysis like you would with a Bell's palsy for the most part.
So I saw a few photos before and afters, of before and afters. Can you explain more in depth how you two work in conjunction? Yes.
Maybe you could talk about your incision,
yes,
because that's really, really important that we haven't discussed yet.
Right. So, we both got trained in head and neck surgery together, and the way we got trained was to make an incision for a parotid that was in front of the ear, would loop behind the ear and come all the way down in the neck, right? And then the skin would be reflected forward, so you have a big view of the parotid and everything around it. And over the years, we kept thinking, well, if the majority of the patients who have parotid tumors have benign tumors, right? We don't really need access to the lymph nodes in the neck in order to treat the parotid gland. This seemed to us to be over-operating for a benign tumor. You're doing essentially something akin to a cancer surgery or a cancer approach to a benign tumor. And as you know, all fields of surgery are going towards becoming less invasive, trying to do the same job, but invade the tissue less, which means cause less injury to the tissue, less scarring, less long-term consequences, allow the person to heal better and faster and get back to their life better. So over time, we evolved the incision to go from something that's right next to the ear, go under the earlobe, and then behind the earlobe. So there is no incision coming down into the neck, it's all behind the ear and just right in front of the ear. So it's well camouflaged in the natural creases of the face and natural transition points of the face. And we found over the years in doing this that we actually have amazing access to the nerves that we want to protect. The nerve that goes to your earlobe, the greater auricular nerve, and the facial nerve, and all the branches of the facial nerve. So the access is not limiting our ability to visualize the facial nerve, protect the nerve, and give good outcomes. And so we have been doing this for over a decade now with amazing outcome without any additional risk, I would say, to the facial nerve at all.
And we have, I think one of the great things about it is healing process is faster. We can do this outpatient. Again, when we were training and actually at a lot of institutions, patients stay in the hospital for several days. We do this outpatient. And from a reconstructive, and the reason you look at our before and afters, you're like, okay, big tumor, gone, patient looks like they've never had surgery, is because we're able to reconstruct this area with the local muscles and local tissues through that same access point that recreates the jawline and the angle of the jaw and the area below the earlobe and in front of the ear as if they've never had surgery. And a lot of times patients come maybe a year or two later and we're like, which side do we do surgery? So that's why I think we've had a very, very fortunate and intuitive approach of doing this operation with a minimal incision that's beautiful and gorgeous and heals like as if you've never had surgery, reconstructed, preserve the facial nerve. And for those who have cancers, we can also do a lot of our reconstruction through the same incision. Bigger cancerous tumors, then we modify our incisions depending on what that situation is. So we have to be able to modify everything that we do to fit the individual.
Right. And the reconstruction is really important because not only does it give the person symmetry, it adds layers of tissue on top of an exposed facial nerve. So now you have extra layers of protection for that nerve, but it also prevents the small little nerve branches that used to go to the parotid gland that instructed it to produce saliva when you were hungry or when you were eating, prevents them from growing into the skin. And when it does, when you don't do a reconstruction and it goes to the skin, what happens is that every time the person is hungry or eating, they would sweat on the side of their face. That's called Frey syndrome, which is really a terrible thing because the patients who have this always have to carry a napkin whenever they're eating.
Yeah, it's really socially embarrassing.
Yeah, it's a challenge because it's an additional thing that they have to be always considering and managing and taking care of. And sometimes they have to inject Botox on that area every couple of months to stop this from happening, or use antiperspirants on their skin, which all of it is really a terrible nuisance and can be entirely prevented. And that's the key thing. All of that can be entirely prevented by simply doing a reconstruction at the time of surgery that gives not only better structural outcome, better cosmetic outcome, but also prevents complications and side effects of the surgery from happening that can really get in the way of your life.
And we don't want you to think about that. I mean, it's a traumatic event to begin with. We want you to not have constant reminders. So all of these little things where the scar is, nearly invisible, the symmetry is fantastic, your facial nerve is intact, you don't have the sweating or Frey syndrome, allows you to move on with your life without a constant reminder of a very traumatic event that has happened in your life.
But the additional thing that I think is really important in the way we work together is the fact that when we have the more complex tumors that we're dealing with, you have two sets of eyes looking at the facial nerve as we are trying to separate the nerve from the tumor. That additional set of eyes, that additional experience really helps protect the nerve even more so, because we're constantly looking at each other's work, assisting each other, making sure the view of the nerve is the most ideal so that the person actually separating the nerve from the tumor can have a better way of doing that and give a better outcome. And that, I think, is just absolutely vital in what we do.
Absolutely. All right. We have two more questions. I got diagnosed with facial paralysis due to a tumor. What should I do? Well, the first thing you have to see, you have to address this immediately.
Yes.
This is number one, meaning like soon, not like in a month or two. This is something that you need to see expert in head and neck surgery and parotid surgery and facial nerve surgery, someone who understands all three things in your area.
This week?
Yeah, soon. So that's number one. Once the tumor, usually a needle biopsy is performed to determine what that tumor is. Imaging needs to be performed to see the extent of the tumor. Those are the basics, unless there's something else that you feel is necessary to be able to then have your surgeons devise a game plan of how to remove it, what reconstruction needs to be done for your nerve, if any, and really something that needs to be managed ASAP.
Absolutely. And in terms of imaging, MRI is probably the first imaging to be done. That gives us the most amount of information. When does the tumor begin? Where does it end? What's the extent of it? What structures is it next to? Unfortunately, the nerve, the facial nerve, is not visible on any of the scans, right? And so, looking at the tumor itself, you can get an approximate guesstimation of how close that tumor is to your nerve. If you have paralysis, which branches potentially are involved or close to the tumor, so you can plan out your surgery based on what you find. CT scan is helpful if the tumor is right against the bone. So the CT scan shows bone structures better, MRI shows soft tissue better. And so when the tumor is right next to the bone of the skull, a CT scan can be helpful to see if the tumor is actually eroding through the bone or causing any kind of issue to the bone itself. And so those studies are important. For benign tumors, which doesn't really apply to this, and you have a small little benign tumor, sometimes an ultrasound will be enough, but if you have facial paralysis, the ultrasound and a CT scan should not be the first choice. It should be an MRI followed by a needle biopsy to see what you're dealing with so you can plan out your surgery, plan out your reconstruction, explain the extent of what needs to be done to the person so that we can prepare and address the tumor appropriately.
Yeah, so but the key thing is immediate attention to this.
Yeah.
Last question is, are the risks for facial paralysis with a parotid tumor greater for someone with a past history of Ramsay-Hunt syndrome? So Ramsay-Hunt syndrome is very similar to Bell's palsy. It's caused by a different virus, but basically what happens is you get symptoms very similar. Complete paralysis, you wake up in the morning and your face is paralyzed. But there's a couple of other things that people get with the facial paralysis. You could have a rash inside the ear because the virus that causes Ramsay-Hunt syndrome is the chickenpox virus. So you could get a rash here. Many people have hearing loss, may have dizziness. So and a deeper facial paralysis that lasts a longer time for it to reverse. So that's kind of Ramsay-Hunt syndrome. Now, if you've had a past history of Ramsay-Hunt syndrome and your facial nerve function is back to normal, the outcome and the results of facial paralysis with a parotid tumor shouldn't be that different from someone who's never had Ramsay-Hunt syndrome, because your nerve has regenerated, it's healed. It's good for your surgeon to know about it so that they're prepared and they understand your history. But I would say that the odds of your nerve getting paralyzed or something like that from a parotid tumor, which is out here, whereas Ramsay-Hunt is a deeper part of the nerve, is probably not that different. So I would proceed with, if it's indicated for your tumor to be removed, I would proceed with that, again, with someone who has facial nerve expertise, head and neck expertise, and parotid expertise, and is doing this operation all the time. And it's not just once or twice a year, it's maybe once or twice a week.
Yeah.
So that's kind of the person that needs to be
I would say
taken care
the
of.
only other thing I would add to it is that when someone has Ramsay-Hunt and you have, let's say, millions of fibers going through the facial nerve coming out, if the Ramsay-Hunt recovery, 95% of the nerve, 98% of the nerves recover, and you just have 2% that's less, you may have full facial movement and not realize that there is just a bit of deficit in that function. And during the surgery, if there is manipulation of the nerve, the chance of temporary weakness is a little bit more because you don't have as much room for swelling and compromise. You have a little bit less room. But in terms of final outcome and having permanent paralysis, I think ultimately it doesn't make a difference if you have had a full recovery from the Ramsay-Hunt syndrome.
All right, wonderful. Well, we want to thank you guys for tuning in on both of our Facebook pages. We're really, really excited. We're actually going to be taping a podcast this afternoon, which we'll let everyone know about in the coming weeks. And we'll try to do this at least a couple times a year so that we can just be able to give you guys some information from two different viewpoints. And we believe really that this is the best way to get better in medicine and to deliver the highest level of care for especially very complicated and complex problems. So we hope you have a great holiday season and a great new year, and thank you so much.
Thank you. Happy holidays, and I'll see you next year.
All right.
Bye.